Hello, I'm Maureen Marsic. I'm Director of Marketing at NeuroReserve. April is Parkinson's Disease Awareness Month, and I'm meeting with Dr. Zoltan Mari to learn more about Parkinson's disease, its risks and genetic factors, and things that we can do to reduce our risk. Dr. Zoltan Mari is a renowned neurologist and clinician-researcher. He's also an expert in Parkinson's disease, and he's one of our medical advisors at NeuroReserve. So Dr. Mari is currently Director of Parkinson's Disease and Movement Disorders at one of the nation's top brain health centers. He previously had an 11-year career as full-time faculty at Johns Hopkins, building the fellowship program, the DBS Center, the Movement Disorder Center, and has stayed on as adjunct faculty since 2017. In addition to his focus on patient care, Dr. Mari is involved in diverse and groundbreaking research, national clinical trials. He's published over 120 scientific medical research studies in the field, which is really incredible. Dr. Mari is also co-founder and chief medical officer for Neurali Inc. and Z Neurosciences LLC. So Dr. Mari, I know there's so much more that you've been involved with in the Parkinson's community. Is there anything else you'd like to share about the work you've done?
So besides those roles, I think it's something maybe worthwhile mentioning that I'm also associate editor of the Parkinsonism and Related Disorders Journal. Mm-hmm. I am also currently the chair of the telemedicine study group for the Movement Disorder Society, mm-hmm. MDS. And I also serve on various committees for the International Association of Parkinsonism and Related Disorders, IAPRD, mm-hmm. which is, by the way, preparing for its annual meeting in about a month in Prague. Mm-hmm. And I will be there, and I'm also on their Congress site selection committee. And I am also working with the Parkinson Study Group, PSG, mm-hmm. where I am the co-chair of the Motor Features Working Group. Wow. And that's an important group because we advise on clinical trial designs and other clinical trial-related matters. The PSG is a wonderful network of movement disorder specialists and clinical scientists who have to be credentialed, as well as we credential clinical research or clinical trial sites throughout mm-hmm. the North American network.
Okay, great. Well, thank you so much for expanding on that. It's obvious that you're an expert in the field, and being a medical advisor for NeuroReserve, we're really honored to have you meeting with me today. So thank you for taking the time.
My pleasure.
So I wanted to start with just talking generally about Parkinson's disease. I think a lot of people think of it as a movement disorder, but it's obviously more than that. So I wanted to see if you could expand on what Parkinson's disease is.
Absolutely, and that's a very nice intro, because not only is it a movement disorder and classified as such, but the field and neurology subspecialty of movement disorders was largely founded and created because of Parkinson's disease. Okay. But I think in more recent years, we clearly and unequivocally realized that disability in Parkinson's disease comes from non-motor symptoms to a great deal, mm-hmm. to some accounts even greater deal, or a greater degree than motor symptoms. And not only that, just think about that. As I mentioned, we do have very effective treatment options for most of the motor symptoms, the classical and cardinal motor symptoms of Parkinson's disease. And because of that, we were able to make these patients forget about them, or if not forget about them, live longer, mm-hmm. Be at least somewhat free from the disability, from right. those motor symptoms where we have effective treatments.
Not experiencing those on a minute-by-minute basis.
Not as much, at least we can mitigate them. Mm-hmm. And that can expose other symptoms because they live longer, they have a more functional life mm-hmm. than before. Because if you don't have any treatments for those motor symptoms, you end up in the wheelchair and you become immobile right. on a quick order. Mm-hmm. And perhaps there is no time and opportunity to bring some attention to those non-motor symptoms, or they don't have the opportunity to be exposed. And now and it's not just levodopa, we have many other treatment options, both pharmacological and non-pharmacological, for the treatment of motor symptoms. And because if you do that well and optimize the care, then you really make a difference. And so that, again, just highlights how less effective we are and successful we are in treating the non-motor symptoms.
And what are some of the cognitive symptoms that people might experience with
Well,
Parkinson's?
cognitive symptoms are one of the non-motor symptoms, and so there are many different ones. So cognitive tends to be an important one that people ask about. In the neuropsychiatric symptoms, or the disorders of mentation, memory, and the mind represent a very important area of disability. That includes depression, anxiety, panic attacks, as well. Parkinson's psychosis is a less common, but nevertheless quite disabling neuropsychiatric issue in Parkinson's disease. Again, part of the non-motor symptomatic spectrum. And cognitive impairment can come early, much earlier than we previously thought. And besides those neuropsychiatric and cognitive problems, there are many other non-motor issues, including those of the autonomic nervous system, the gastrointestinal system, hypotension or orthostatic hypotension, when you stand up and your blood pressure drops due to the loss of vascular reflexes, is very disabling, very common. And again, we don't have a lot of success stories, because we do have pressors, medications that elevate the blood pressure, but they have also very significant limitations. And I would say that overall, the non-motor symptomatology, or the disability from non-motor symptoms in general, tends to be a harder nut to crack, or a harder area of disability to successfully and effectively treat than, generally speaking, the motor symptoms.
Well, and the motor symptoms are easy to see, and people are experiencing them on the outside, where it's obvious if there's an improvement or if it gets worse. So that makes sense. I can understand that.
Yeah, but also I think most patients get disability in the earlier stages of the Parkinson's disease from those motor symptoms, when the overall disease perhaps is not as severe. And that is also part of why people call it the honeymoon period, where things are looking really good. And with optimized treatments, many of these early stage patients can be restored to near normal functional status. They can still work, they can put up with very little inconvenience, taking pills perhaps, and do quite well. As the disease progresses, while many of those motor symptoms continue progressing beyond what even effective treatments can fully restore. And I just like to make this point, which comes up often, that it is not necessarily because those treatments lose their efficacy, which patients will narrate, they read it online, and that's kind of a misconception that is very common. They will stay effective, but the disease will be worse. And so even if you will always be worse without treatment than with it. So the effect will be there. It's just that you're dealing with a more severe problem. And then, of course, the emergence of many other, as I said, it's a multi-system disease with many different disabilities hitting from many different directions. And even though your tremor is still well treated, at that stage, 15, 20 years into the disease, you might not even care about the tremor as much as you have other major issues with cognitive impairment, postural instability issues, hypotension that I mentioned, severe depression, and the list goes on and on.
And I was going to ask about those additional symptoms. So thank you for mentioning that. I think one of the other things I've read about is that Parkinson's patients will get rigid muscles, or trouble with their gait, or like a shuffling gait. Are those some of the other symptoms that they might notice?
Yeah, so those that you mentioned, the rigidity and postural instability, are in fact part of the so-called cardinal motor features of Parkinson's disease.
Okay.
And there are 4 of them. The one that most people recognize is tremor, which is resting tremor, but the truth is that it's not the most common motor symptom or cardinal motor symptom out of the 4. About 2/3 of patients will have tremor, and the other third, they don't have tremor. And besides tremor, the other 3 cardinal motor symptoms are bradykinesia, or slowness of movement.
And that's bradykinesia?
Bradykinesia. Okay. And that is the most common one. In fact, a patient wouldn't meet the clinical diagnostic criteria if they didn't have bradykinesia. Okay. So that is 100% of patients must have, by definition. That's how the clinical diagnostic criteria are defined. So bradykinesia, tremor, and the 2 you mentioned. Rigidity is a increased muscle tone, which is in a particular way. Muscle tone may be increased in various ways. In neurology, we describe them as paratonia, or holding against, spasticity, which is a clasp knife type of increased muscle tone, oftentimes seen in stroke or spinal cord injury, etc. And rigidity, which is classical for Parkinson's disease, but it may be seen in other related disorders, is a particular ratchety type of, we call it cogwheel rigidity. And then we call PIGD symptoms, this postural instability and gait disorder, as a group that can include stooped posture, shuffling gait, tendency to fall, a loss of postural reflexes. That is the 4th cardinal motor feature of Parkinson's disease.
Okay. I think the most for me, that was interesting to hear about the cognitive impairment, because it's not something that you typically hear about. It's always been, like I said, I think people think about it being a movement disorder, but there are so many other things that come about with Parkinson's. So that's
one of the most feared ones, because if you keep your senses and if you keep your clarity of mind, you can still find things to enjoy in life. You can still read, you can still watch the news, you can still participate with your grandkids, and many things that will give you joy if you have that sort of mindset. Because of course, a crippled and very difficult to move body would be a reminder that you don't have your full abilities. But I think the last ability that people look to lose, or nobody's looking to lose anything, but that they tend to be most sensitive about is their intellect, their cognitive abilities. And so it is something that is part of the Parkinson's disease presentation. But I like to emphasize that Parkinson's disease tends to be quite heterogeneous, which means that there are no 2 patients that are exactly alike. Okay. There are many similarities, and of course the clinical diagnostic criteria that I referred to earlier needs to be met. But beyond that, the severity of some of these symptoms, the exact pattern of these symptoms, their timeline, and the perceived disability from them varies very much among patients. Right. And cognitive impairment is no different. In fact, that may be the most variable among them. Overall, it's not as bad as you would expect in some other dementing illnesses, such as Lewy body dementia or Alzheimer's dementia or frontotemporal dementia. Okay. On
there
average,
are some people that develop Lewy body dementia at near the ending stages of Parkinson's. Is that right?
So this is a bit of a controversial topic. First of all, we believe that mixed pathologies are probably more common than we previously realized. When I was trained in neurology, our attendings taught us that if you can't boil it down to a single disease and a single pathology, you are not a good neurologist. So we had to localize to a single locus. We had to find a single etiology and to somehow explain every symptom through that. Now we know from autopsies and other data that view is not realistic. It's not really consistent with the actual world, because multiple pathologies are very common. So both Lewy body dementia or dementia with Lewy bodies, and Parkinson's disease are synucleinopathies. The underlying pathology involves a brain protein called alpha-synuclein, and so that connects them. And as to how you define each disease and what distinguishes them, there's still controversy, and then there's still some arbitrary definitions there.
So are there any risks or genetic factors that make people more vulnerable to developing Parkinson's?
Absolutely.
Maybe you can cover kind of the big ones that people should be aware of.
Absolutely. And when we are discussing genetic risk, it is important to emphasize that Parkinson's disease may not be a single disorder. It's a common question. Is it a syndrome? Is it a mix of various causes and perhaps forms of pathologies or variants of pathologies that ultimately converge to looking similar in some ways, but not the same disease entirely. When I'm asked about genetic risk or genetic factors, does it run in the family? We need to point out that, number one, there is no known mutation at the moment that will certainly predicate some Parkinson's disease at some point in the patient's life. So there's no, like for instance, I always use the example of Huntington's disease. If you have a certain number of repeats, the severity of the genetic mutation or abnormality in Huntington's disease is measured by the number of a trinucleotide repeat. And if you have a certain number of repeats, let's say 40 plus or 45, say, then it's just a matter of time that you will certainly have the disease if you live long enough. There are many different mutations and so-called risk genes in Parkinson's disease, but there is not one of them which looks like the Huntington's mutation, in which you know for certain that you will have the disease. It will always remain just a risk gene, which means that if you have a mutation in that gene, then you have an elevated risk of Parkinson's disease at some point relative to somebody who doesn't have that mutation. Now, there are many other factors that can play into this, including environmental exposures, including nutrition, including exercise, including a lot of other factors that may or may not play a role in how that risk associated with certain genes, or the lack of certain genes for that matter, because there could be protective genes too, will be modified or play out in real life. So even if you have an identical twin sister and you have the same genetic makeup, the same genome, some of those genes that you both have could have an impact on your Parkinson risk. How that will play out in each of you may not be the same, because you may have different exposures throughout life, and that could prime or impact the risk that you carry from your genetic makeup or genetic predisposition. And so that's one factor, environmental.
And I just adding to that, I'd read that exposure to herbicides and pesticides could be a factor. Is that something that
absolutely. So there are many environmental factors, toxins and others that have, drinking well water, for instance, that have been well established as environmental risks as well. But to sort of highlight how the interplay between genetic predisposition and environmental exposure may play into each individual's risk, you can think of pesticides or pesticide exposure. Clearly established, it's a major risk. Yet, if you take 100 individuals who were farmers and they were exposed to the exact same amount of herbicide or whatever, rotenone or one of those very high risk toxins, out of the 100, let's say it's a very big risk, and 9 will come down with Parkinson's disease. That's the highest I can think of. It's almost 10% risk.
So just because you're exposed to those toxins doesn't mean you're going to get Parkinson's.
Well, the other 91 didn't, right?
Right.
So why is it that this 9 had it? And by the way, the lifetime risk of Parkinson's is about 1%. So if in your lifetime, if you remove or average out all of these exposures and genetic factors and everything, you have about 1% chance of developing Parkinson's disease in your lifetime. And that is what everybody is born with, and that is what is modified by certain factors, or we know that the 1% could be more if you have one of those so-called risk genes. And by the way, they are not that common. At least we don't know all of them. We are discovering them still, and I'm sure there will be many more. I think the more common ones we probably have identified already. What we have not identified is the less common one, and also the whole notion of what about the combination of them? What if you just don't just look at single gene risks and sort of risk analysis based on one gene, but combine that with big data and other higher order analytic techniques to look at how they modify each other and how they work in multiple. But anyway, those monogenic sort of genetic risks that we do know, it seems that the ones that are relatively more common are a relatively smaller risk, whereas the ones that are higher risk they tend to be less common.
Okay. And are men more likely to get Parkinson's than women?
Yes, they are. The ratio is approximately 2 to 1.
Okay. I didn't realize it was that high.
Yeah, different data look differently. At least 50% more men will come down with Parkinson's disease than women.
Okay. So you spoke a little bit about lifestyle factors. So I definitely want to go into that a little bit more. But before we do that, it seems like chronic diseases often are driven by inflammation. And so it'd be interesting to get your thoughts on that. From what I've read, Parkinson's disease is no exception. It's also can be driven by inflammation. So I'd love to hear your, just how things can go wrong with the cells in our brain and how inflammation plays a role.
Yes, and this is obviously a very hot and very intensely researched topic at the moment. In fact, I came from a PD grant rounds where partially this was discussed. It's very interesting, it's very relevant, and I would say not completely understood. One is that whether neuroinflammation is universal within Parkinson's disease. And increasingly, we believe it's not universal.
Interesting.
In some cases, it may be the main factor or the leading causative factor that drives the whole pathological process. In other cases, it could be present, maybe not as severe, maybe some corollary or just a sideshow or collateral damage. And in some cases, it seems to be absent. So when it comes to cause and causation, there's another area of not fully understood mechanisms. Is the neuroinflammation something that causes it all, or is it just a reactive response in the brain in response to the primary pathology? And these questions are not fully understood or answered quite yet.
Okay.
We do know that in a large number of individuals, there is going to be microglial activation. And microglial activation, as described by the Dawson lab in Johns Hopkins, is identified as leading to certain inflammatory cytokines released and activating the astrocytes to become induced A1 astrocytes, which can then inflict the damage.
Okay.
And so that seems to be correlating in various animal models and autopsies with the synucleinopathy, which I mentioned is very fundamental to the Parkinson pathology. So that is well documented, and there are many brains where there is very good correlation and colocalization of microglial activation and synucleinopathy.
Okay.
At the same time,
say that again, microglia, is that how I say it?
Yes,
And
microglia.
astrocytes, those are both cells in the brain?
Those are both
They're not
cells.
neurons.
They are
Okay.
not neurons.
Okay.
So there are two types of cells making up the nervous tissue, because there's also vascular tissue and connective tissue and other things
Right.
in the dura and everything. But in the brain tissue itself, there are two main classes of cells. One are called glia, and the other is neurons.
Okay.
And there are many different types of each, but those are the two types of glial cells that are relevant to neuroinflammation, microglia, as well as the astrocytes.
Okay. So I wanted to talk a little bit, you touched on lifestyle factors earlier. So I'd like to talk a little bit more about those lifestyle factors and things that people can do to reduce their risk. I know a lot of people in our NeuroReserve community are always looking for ways to reduce their risk of Parkinson's or Alzheimer's or other dementias. So can you share some of the lifestyle factors that people can do to reduce their risk?
So there's risk and also impact by lifestyle on the disease if you already have it.
Oh, right.
And so I would like to start with that there's quite a lot of evidence now that lifestyle, especially exercise, makes an impact on the disease itself once you have it. So in other words, you are able to condition your body, making it more resistant to the decline or the changes to come from the progression of Parkinson's disease. We don't know if there is perhaps more to that. It is possible that exercising and being active will do something more than just conditioning your musculoskeletal system or the nervous system or the motor system or any system. It may be that there's some molecular and neurochemical and other factors that correlate with exercising for why patients who exercise tend to progress slower.
We've seen that actually, sorry to cut you off, we've seen that with a friend of ours at NeuroReserve. His name's Jimmy Choi.
Oh, yes.
Are you familiar with him? The American Ninja Warrior?
I have done programs with him before, most recently with a Parkinson's place. And of course, he's a well-known individual.
He's so inspiring. But I know he's really been able to manage his symptoms of Parkinson's with exercise.
Absolutely. And there are actually relatively well-controlled studies as well, which address the notion of exercise. Again, we don't know that for sure, and there's not enough data to say one way or another the mechanism of exercise's effect. There are many theories. They are very hard to prove, and they are probably going to need a long time and large studies,
a lot more studies
to go after that. But I always tell patients that ultimately it doesn't really matter, because we know it works. We know that if you're exercising, you will be better off.
And are there is there evidence that certain exercises are better for the reduction of risk, or, for people that are maybe concerned about, maybe they've had a family member that's had Parkinson's, and we know genetic risk.
Yeah, we're gonna go back to the risk in a moment, but to say that in Parkinson's, when it's already diagnosed, it's the two most common questions, like what kind of exercise should I do? What is the difference between one and another? And then how much is not too much or not too little? And so
what's that sweet spot?
And so these two questions, which are the most common questions, my short answer is I don't know.
That's fair. That's okay.
Because there have not been controlled and high quality studies to assess that. There have been studies, and there's no clear emergence of what type of exercise. We know that if you can exercise too much, that can actually hurt. There was a study that actually showed that.
Okay.
As far as what kind of exercise and how much, my answer, because I don't like to say I don't know, but
people always want some answer, right?
right. So my answer is the good exercise, the one that you're going to actually do.
That is fair. I like that.
Because if you do something that you hate, it's just a matter of time before you stop doing it.
Right.
And so my short answer is always that the good exercise is the one that you like, the good exercise that is sustainable because you like it, because and I always explain to patients that liking it, that positive feeling that Jimmy Choi and many others experienced will not come the first day.
Right.
Not even the first week. And that's true for us who don't have Parkinson's disease, that we need to get through that bump in order to get the high from it. And once you get to that point, it will help. It could be stationary bike, reclining bike, swimming, terra bike. The list goes on. Just simple treadmill as long as it's safe. Weights. I also there are some patients who really take it seriously, and I tell them that if you can mix it up, that's probably you're gonna cover more ground or hit it at more cylinders.
Right.
It's just kind of an instinctive advice. So somewhat of a mix of activities, and again, the guiding principle is something that you like and will do.
Right.
Now, coming to the effect on risk, that's less clear. So as much as we have, I could say, substantial evidence to demonstrate that exercise is beneficial on your Parkinson's and your long-term outlook and the disability. And again, we don't know if it's disease-modifying, neuroprotective, or just conditioning, or all of the above. We don't know that, but we do know that it will help you look better and minimizing the impact of Parkinson's disease and disability to some extent if you exercise versus if you don't.
Right.
So that's I can say that.
Okay.
One thing for sure, you're not going to hurt your risk by exercising, and certainly exercise has many other benefits besides Parkinson's disease.
Right.
So just because there is no big flashing sign that it will prevent your Parkinson's disease if you exercise, minus that big sign, I still think that exercising can only help.
It's still a good idea. Okay, well, that's great. Another lifestyle factor I wanted to talk about with you is diet. And of course, at NeuroReserve, we're really focused on the nutrition side of prevention and reducing people's risk of Parkinson's, dementia, Alzheimer's. And there was a recent study that came out from Rush University Medical Center that explored the MIND diet, which for our viewers who are listening to this, it's very similar to the Mediterranean diet. But it sounds like the study found that people who followed the MIND diet were able to either delay the onset of Parkinson's or slow the progression of the disease. So I wanted to get your thoughts on that and what your thoughts are on nutrition.
Absolutely. And I'd like to first say about the Rush study that Rush is obviously one of the most preeminent movement disorder centers in the country, but also in the world. And when I mentioned that early studies perhaps lack the science and the methodological rigor to really investigate these ideas are now being corrected. So this is one example how we are moving from sort of early stages and perhaps some methodological questions and problems and mistakes to much higher quality studies where those are properly addressed, proper controls are used, properly powered, properly run and recruited larger studies that actually will get us good answers that we can rely on. So I'm glad that you brought that up, and I'm sure there will be many other studies, not only just generally among Parkinson's disease, but with our abilities of using technology, smartphones, and all different things. It will be increasingly possible to track every individual exactly what they eat and then track it down in a more stratified manner. The reason I say that is because clinical diagnosis of Parkinson's disease may not give you the whole story of every individual, how certain diets or certain nutrients or certain lifestyles will matter for that one individual versus another. If you group them together and just use the clinical diagnostic criteria as your enrollment, then you might dilute those things, or you might miss those. And one of the reasons why we didn't have any better ideas of doing it is because how do you select those strata based on what criteria? And who has the time and money to go after just one rare genetic abnormality, or patients who have that? It takes 1,000 years in order to enroll enough individuals that could power the study to get your question answered.
Right.
So with big data, with the improvement of technology, I think we are opening the window to make what was previously not realistic to do realistic. And also we are understanding more about the individuals and their genetic makeup, because data and analytics have exploded in the last 10, 20 years with the computing abilities skyrocketing, or data science, frankly, also developing in leaps and bounces. So I'm very optimistic as to where this direction is going. That's and good. We will certainly be very interested in learning more and more.
Okay.
Having said that, what's already well known is that a good chunk of individuals do have some form of neuroinflammation. We know that there are some nutrients and supplements and dietary adjustments that can calm that down to some extent. And while it's not proven to the point of certainty, it is natural that if something doesn't hurt you, it could help. And there's good preclinical and in other biochemical reasons for why it should help, then I encourage that.
That's great. Thank you. Well, to wrap things up, I wanted to just talk a little bit about the future of Parkinson's and where things are going. So, for people who are already diagnosed, what does the future look like for treatment and things of that nature?
Thank you. And I do have, as I mentioned, a lot of optimism in terms of the future. And I think with all these new data, new understanding, new methods, new abilities, we are truly accelerating our science. And it is true for symptomatic treatments. It's true for our research into disease-modifying treatments, which none of them have been proven or approved yet, but there are many, many very promising studies, including those enrichment techniques to improve your enrollment. I mentioned earlier that I have a problem with just using the clinical diagnostic criteria alone and kind of considering all these patients clones of each other from the perspective of nutrients or interventions. Now that we know more and more about these patients, I think the so-called precision medicine or personalized medicine is within arm's reach.
Okay, I was going to ask about precision nutrition.
So precision medicine would be able to narrow down your individual, very specific and unique problems as you have them. And as I mentioned, comorbidities and simultaneous pathologies are much more common than we previously thought. And how our research studies and the results from those research studies can be extrapolated to the entire disease group if we exclude comorbidities here. And, it's still a sort of a moving target and an evolving field. But I think with our ability to better characterize individuals and strata, subgroups within Parkinson's disease, or certain particular pathologies, which may be just a minority of the entire clinical Parkinson's disease, but this is there is a very important minority or small stratum, because we can identify a mutation or some other molecular abnormality, which we have some way to target. And then maybe we also have a way to measure whether we are doing well, other than just using the clinical exam as our primary endpoint, but using some molecular markers, other objective measures to tell much quicker and in a smaller number of individuals whether we are making a difference or we are making the therapeutic difference that we would like to accomplish. So for patients who already have Parkinson's disease, I think the first reason for optimism is that we already have a lot of treatments that work well. We have improved in understanding Parkinson's disease as a multi-system disorder, and we approach it as an integrated, multidisciplinary manner. And we all talk to one another, and we take into account what is actually disabling the patient and apply an optimized set of treatments to match the patient's disabilities, things that really matter to them.
And I know you talked about how each patient presents the disease in different ways.
Yes, right? And just one example to demonstrate that, levodopa-induced dyskinesias are abnormal involuntary movements that could look funny, it could be disabling, it could be distressing. Now, patients not always develop that, but a lot of them in advanced stages will. And I often demonstrate that to a trainee that works with me in the clinic, that a patient with a degree severity 2 or 3 dyskinesia walks in, and it will get the attention. It's very dramatic. And then everybody will start talking about that, just assuming that, well, the patient looking like this must be their number one problem. So let's help them with their number one problem before you even ask them.
Right. And there could be other cognitive issues that they're experiencing.
It could be a lot of other issues,
issues.
But then you say, well, what about this dyskinesia? And they don't even know what you're talking about because it's so normalized to them.
Right.
Plus, it's oftentimes associated with their ability to get up and go to the fridge for a cup of water or ability to walk and move around. Whereas when they are not dyskinetic, that means they are off and they can't move. So in other words, it's not bad at all for them.
Right.
And then another individual with the same degree or severity of dyskinesia walks in next, and that's all that they can talk about, that this is driving them nuts.
Okay.
So that's just a demonstration of the same symptom could be perceived very differently based on the patient's mental status, priorities, values, etc. And that's why I always say, first of all, ask what bothers them. I always ask this question: if I had a magic wand and I could make 3 symptoms just go away, tell me which 3 would that be? And basically, they can say anything: fatigue, sleep problems, depression, stomach issues, stomach pain, gastroparesis is a common one. So the bottom line is that you would be very surprised as to what answers you get to that question. And so, again, the reason I say that is because we have a lot of effective ways of treating symptoms with what we already have, as long as we really understand and individualize it based on what the patient needs.
Right.
And it's a dynamic game. It's not going to stay that way. You have to ask that question again 3 months and 6 months later,
it keeps
because
changing.
Things change. And so that's one thing. But at the same time, there are very advanced efforts right now ongoing in the disease-modifying and neuroprotective arena. And I don't want to overpromise and underdeliver, but I think we are very close to some of these studies finally producing some tangible and positive results as far as slowing down the disease progression. That's what everybody wants to hear.
News, right.
That's the so-called holy grail in Parkinson research right now. And I think we are close. There's a lot more to call it a breakthrough, because if you just have one agent that meets that endpoint, there's still a lot of work to be done.
Right.
And I think that polypharmacy, or multiple different things combined, as well as adjusted and optimized, just like we do with symptomatic treatments, is probably going to be in the future.
Okay.
With regards to once we have these disease-modifying neuroprotective treatments finally shown to be doing something.
Well, I'm excited to hear more about that in the future. That'll be
and the final future, because a lot of times I am asked, like, when are we going to have the cure? And I have the disappointing answer that probably never, because in order to provide a cure, like you can cure a UTI or even a pneumonia, going back to a restoration to exactly the point where you were 2 weeks ago before you had the UTI, because that's 2 weeks, and Parkinson's disease is 20
It's
years.
a slowly progressing disease.
Unless you find a way to go back in time, you can't cure it.
Right.
Now, restoration will be partially possible, but I think what is even more possible in the distant future is prevention.
And that's what I was going to ask about next.
Once we understand exactly what the pathological process is, we will identify and know how to find individuals who are at high risk or in that preclinical or prodromal state that I talked about before. We could just catch it in its track. So if a patient had Parkinson's for 20 years and they are in a wheelchair and they have very severe disability, both from motor and non-motor symptoms, even if we had a neuroprotective treatment which completely halts the progression of Parkinson's disease, whatever the pathology is, we put completely cold water on it, it's not going to go any further. You still have aging. And if you have lost so much of your brain already due to the neurodegeneration, it doesn't have the normal reserve that is able to offset some of the aging-related problems, because normal aging will eat your brain too, right?
Right.
And if you have an otherwise healthy brain, you have quite a bit of reserve to account and offset that aging-related decline, right? Now, if your brain is not starting with a full deck of cards, because neurodegenerations already did a number on it over the past 2 decades, then even if there is no more pathology, no more Parkinson's disease at all, at that point, the normal aging will have the upper hand because you don't have a full deck of cards, because you don't have the ability to compensate and offset that change. So you will still be going downhill. So, but of course, when are we going to have something that completely stops the pathology? We are not that close. What we are talking about is something that slows it by 20% or 30%. That would be clinically significant, right?
And that would be wonderful news for people that are worried about.
Exactly. So if you had something that's 30% effective, and you were able to identify individuals in the prodromal state as early as possible and apply that, then they may never develop Parkinson's disease, because that 30% could assist their still healthy brain to compensate, and of course exercise and everything, right? But then it may make the difference between a 50-year-old who was going to develop Parkinson's disease at age 65 or 64, living to 80 plus years and never have that.
Right. And that's the wonderful thing that I think people can get excited about.
And it's totally realistic. As I said, cure in the restorative sense will only be possible if you figure out how to reverse time and the flow of time. Now, for the prevention, on the other hand, that is within the realities based on what we know today.
Well, Dr. Mari, thank you so much for meeting with me today and taking the time to educate us all about Parkinson's disease.
My pleasure.
It's been a great conversation, and I look forward to meeting with you again.